For the cover test and alternating cover test, begin by explaining the procedure to the patient. Inform the patient that the purpose of the test is to assess for any eye misalignment or deviation. Ask the patient to fixate steadily on the target provided, either at distance or near, and instruct them to let you know if the target become blocked from their view during the test. Ensure the patient is seated comfortably at the eye level in a well-lit environment. Start with the cover test. Cover one eye completely using occluder while carefully observing the uncovered eye for any movement as it takes out vision. Then, uncover the eye and observe for any corrective movement as binocular vision is restored. Perform the test as the both distant and near fixation. Alternate several times to confirm your findings. Next, proceed with the alternating cover test. Ask the patient to continue fixating on the same target. Cover one eye for a few seconds, then quickly move the occluder to the opposite eye without allowing binocular fixation. Continue alternating the cover between the both eyes while observing the uncovered eye for any refixation movement as each time the cover is shifted. Repeat the procedure several times at both distance and near fixation to assess the consistency of the ocular alignment response.
Moving on, we'll be now presenting methods to assess ocular deviations.
This patient has a constant right exotropia, and during the cover-uncover test, when the left eye is covered, the right eye will move inward to take up fixation. This movement indicates a manifest deviation or tropia because the right eye was not fixing initially. And then, when the left eye is uncovered, the left eye regain fixation and the right eye drift outward again back to its primary position. Then, when the right eye is covered, the left eye remains steady with no movement because it already fixing on the target. When the right eye is uncovered, no movement is observed. During the alternate cover test, binocular fusion is disrupted by alternating cover each eye. So, when the left eye is covered, the right eye move inward to take fixation. Then, when the cover shifts to the right eye, the left eye remains fixing while the right eye drift outward beneath the cover. This repeated refixation movement confirms a constant manifest exotropia.
So now, I will demonstrate on how to assess ocular deviation using the cover test, focusing on constant alternating exotropia. Constant alternating exotropia means both eyes drift outward and either eye can take up fixation. There is no single dominant eye. So the first one is to begin with the cover test. Place the occluder over the right eye. Watch the left eye carefully. If it moves inward to take up fixation, this shows that it was previously deviated outward. Now, switch the cover to the left eye. The right eye moves inward to fixate, meaning it too was deviated outward. This alternating inward movement confirms that both eyes shows outward deviation. When both eyes are uncovered, one eye always drifts outward while the other maintains fixation. As the cover alternates, the fixation alternates between eyes. In constant alternating exotropia, each eye moves inward when uncovered, revealing an outward deviation when fusion is broken. The fixation alternates between eyes, confirming the diagnosis.
This patient has intermittent exotropia, so during the cover-uncover test, there may be no obvious movement because the patient is still able to maintain fusion. But during the alternate cover test, the fusion is completely disrupted by alternately covering each eye. As fusion is broken, the deviating eye drift outward beneath the cover. When the cover is shifted, the uncovered eye make an inward refixation movement to regain fixation. This refixation movement reveals the intermittent exotropia. For recovery, is assessed after the cover is removed. The speed at which eye return to normal alignment indicate the patient control of the deviation. Fast recovery indicate good control, while slow recovery suggests poor control of the intermittent exotropia. Other than that, the patient can recover by blinking. This happens when the eye doesn't immediately return to normal alignment and the patient requires a few blinks before recovering fixation. This recovery by blinking indicates that the patient needs additional effort to regain binocular vision.
Now, I will demonstrate on how to assess ocular deviation using the cover test focusing on esophoria. Esophoria is a latent deviation where the eyes have a tendency to drift inward. Under normal binocular vision, fusion keeps them aligned so the deviation is hidden. First, look at the patient's eyes at rest. They look perfectly straight because both eyes are working together. To begin the cover test, place the occluder over the left eye. The right eye remains steady, which tells us that there is no manifest queen, which is no tropia, but the covered left eye drifts inward because fusion has been interrupted. When the cover is removed, the left eye quickly moves outward to realign with the right eye. This outward recovery movement reveals the underlying esophoria. Now, cover the right eye. The left eye stays fixating, while the right eye drifts inwards under cover. When uncovered, the right eye moves outward to regain alignment. Every single time an eye is uncovered, we will see it jump outward. This is because we already break their binocular vision completely. The eyes are taking turns resting in the inward isophoric position. Every time the occluder moves, the newly uncovered eye has to make that outward correction. Next, we switch to the alternate cover test, moving the occluder back and forth between the eyes without letting both eyes see at the same time. Finally, we remove the occluder to watch the recovery. For this patient, she has small isophoria with fast recovery. This indicates that this patient has good recovery and strong functional control, meaning their eyes easily overcome the isophoria in daily life.
During oculomotility testing, OMT, assessing eye movement systemically is essential to identify any extraocular muscle dysfunction. Asymmetry across different cases may indicate underlying pathology, but careful analysis is required to determine whether the finding is clinically significant or simply a normal variation. When asymmetry in movement is observed, I would first evaluate the eyes in all 9 positions of gaze, comparing both eyes to identify any limitation or excessive movement. This helps in detecting possible underaction or overaction and whether the asymmetry is case-dependent. Next, I would compare versions and ductions. Versions assess binocular movement while ductions assess monocular movement. If a limitation is present in both, it suggests true muscle weakness. However, if it appears only in versions and not in ductions, it may indicate a relative imbalance due to yoke muscle involvement rather than true underaction. I would also apply Heron's law of equal innovation. Increased neural input to compensate for a weak muscle can cause apparent overaction in the contralateral yoke muscle. So it is important to distinguish between primary and secondary changes. Then I would grade the findings using the standard scale from -4 to +4 to determine the severity and whether the asymmetry is clinically meaningful or within normal limits. In addition, I would consider associated clinical signs such as diplopia, abnormal head posture, incompetency, and the quality of eye movement, as these indicate functional significance. Finally, I would rule out non-pathological factors such as poor patient cooperation, fatigue, or mechanical restrictions, and confirm the findings with additional tests like the cover test or prism cover test. By integrating all these factors, I can determine whether the asymmetry represents true underaction, overaction, or a secondary compensatory mechanism.
In oculomotility testing, we always look at both versions and ductions. Versions are binocular movements on how both eyes move together in the 9 cardinal positions of gaze. Ductions are monocular movements on how each eye moves individually when the other is covered. Comparing these two is essential because versions alone can sometimes mask the true problems. For example, if one eye is weak, the fellow eye may reduce its movement to maintain coordination due to Heron's law of equal innovation. This can make the weakness look less obvious. By isolating each eye with ductions, we can see whether the limitation is real or just a binocular adaptation. This comparison also helps us distinguish between different causes of motility problems. If ductions are limited, it suggests a mechanical restriction or nerve palsy. But if ductions are full, while versions are abnormal, the issue may be binocular coordination or innervation imbalance. In other words, ductions tell us that the maximum capacity of each eye, while versions show how the eyes work together. Clinically, this prevents misinterpretation. It allows us to decide whether the deviation is due to a cranial nerve palsy, a mechanical restriction like thyroid eye disease, or a supranuclear disorder. Without comparing both, we might miss subtle underactions or overactions or mislabel the problems.
For extraocular muscle, the findings are graded from -4 to +4 to describe the amount of underaction and overaction of the extraocular muscle. The grade 0 means normal eye movement, and for grading -1 to -4, it indicates underaction or limitation of movement. For example, -1 is slightly limitation, while -4 means the eye cannot move in that direction at all. Right. For positive grading, it's from +1 to +4. Indicate overaction of the muscle. +1 means slight overaction, while +4 represent severe overaction. This grading is important in OMT because it improves communication between optometrists and other eye care professionals. For example, when a clinician grade the muscle action as -3 or +2, other optometrists can easily understand the patient condition and whether it is mild or severe. This makes patient management more consistent and efficient. Grading also helps in clinical decision making. For example, severe muscle limitation may suggest cranial nerve palsy, restrictive disorder, or muscle weakness, which may require further investigation, referral, or treatment. While in my finding, may only need observation and monitoring. Besides that, grading is useful during follow-up visit because it can help in comparing the grading over time so that clinician can determine whether the condition is improving, stable, or directory for each follow-up visit. However, grading also has limitation. This is because the assessment is adjective, so it depends on examiner observation. For example, one optometry may grade it as -2, while other may consider it -3. This can cause variation between examiner and it will affect the consistency.
In this part, I will discuss how to decide which test to prioritize in a patient who is suspected in committing deviation by using the ocular motility test, prism cover test, Hess-Chart, and diplopia charting. And I will also explaining the strength and the limitation of each method. Firstly, the prism cover test is usually prioritized during the initial assessment because it provides a quantitative measurement of the deviation in different gaze positions. Its main strength that is objective and reliable and also helps to monitor changes over time. However, it's need a good patient cooperation and does not give a detailed information on which muscle is affected. Next, the ocular motility test is OMT, used to evaluate the extraocular muscle function by observing the eye movement on 9 gaze position. And the strength of OMT is simple, quick, and helps to identify possible muscle weakness or restriction. However, this OMT is subjective and highly depend on the examiner experiences. Then the Hess-Chart is usually prioritized when the detailed analysis of the muscle imbalance is needed, especially in paralytic strabismus. It provides a clear visual representation of the underacting and overacting muscle, and also it helps to monitor recovery. However, it requires a good patient understanding and cooperation, so it needs is not suitable for patient with a young children. Lastly, diplopia charting is mainly used for the adult who complain of double vision. It helps by identifying the direction and position of diplopia in different gaze positions. It's saying that it reflects the patient symptom directly. However, it is subjective and highly depend on the patient response. In conclusion, the prism cover test and ocular motility tests are usually performed first for a quick assessment, then followed by the Hess-Chart and diplopia chart for a more detailed information needed. Thus, the combination of these tests to help to more accurate diagnosis and management of the concomitant deviation. Thank you.